Hello friends, this is a case of total laparoscopic hysterectomy and appendectomy in the same patient with the 3-5 mm port. So, here we have used the infrared ureteric catheter and the uterus was pushed cranially by colpotomizer, and there is a contralateral traction because we will start with the right side, and we are using round ligament here first with the ligature. And after that, this is the fallopian tube, and then this is ovarian ligament, and here this is the meso-ovarian, mesosalpinx, and 2.5 centimeter over broad ligament. We can see ureter is nicely visible with the infrared ureteric catheter. And now it is left side. Here we will keep the ovary, so we are not taking the IP ligament. So this is fallopian tube, and here again this is the ovarian ligament. After that, you can take 2.5 centimeter over the broad ligament. Now uterus will be pushed retroverted at 5 o'clock position, and then this is anterior leaf of the broad ligament. Here we are using harmonic, and the assistant will push the uterus from 5 to 7 o'clock. Now again separating the bladder. Colpotomizer is pushed hard, bladder pillar is separated. So both the side of the bladder pillar is separated. After that, we will take posterior peritoneum. For this, uterus should be fully anteverted. And above the arc of uterosacral ligament, posterior peritoneum will be separated. Because we are using only 3 ports, so other side of peritoneum also will separate from the same side. And now it's over. After that, next step is uterine artery. So this is uterine artery of the left side. So you can coagulate at twice and then cut in between, and it is cut. If you have a little reverse bleeding, you can catch again, and it is coagulated. After that, this is the left side. We apply a lot of betadine in between the jaw before taking uterine artery, so that overcooking will not be there and sticking also doesn't happen. So that is our usual practice, and this is the other side of uterine is also done. After that, this is the colpotomy started, and the assistant will keep on rotating the colpotomizer, and we generally start above the arc of uterosacral ligament, so that vaginal part of uterosacral ligament will not be cut, and slowly this is lateral colpotomy. After that, anterior colpotomy. And then this is right side colpotomy. Ideally, if you have a 4 port, then this side of colpotomy you should do from the same side. and this is a little bit remaining posterior. So hysterectomy is over, Now we will remove the uterus and we will do salpingectomy. So this is the left tube. Anteromedial traction will be given, and this is a sponge holding forceps which will take the left tube out. Now this is the right tube, again anteromedial traction, and this is the mesosalpinx, and then it is the right tube out. After that, this is the appendix, and with the ligature we will cut the mesoappendix, and slowly we have to go up to the base of the appendix. This patient has the previous one episode of appendicitis, and slowly it is separated. We must reach up to the cecum to prevent incomplete appendectomy. And now we can see we have reached up to the tinea coli. So proper skeletonization of the mesoappendix is necessary. After that, now it is reached. Now we will use Misra's knot here, that is extracorporeal slip knot, with the Vandarkar knot pusher, and you will put the grasper into the loop and then bring the knot at the base and slide it. Tip of the knot pusher should be kept over the base, and automatically entire knot will slip there. Here we are using harmonic scalpel to cut the suture. You may use scissors also. After that, appendix is removed. Appendix is cutting, leaving 3 to 5 millimeter from the base. And it is taken through the vagina itself. There is a sponge holding forceps, and then you can take the appendix out. After that, we are putting little betadine, because you have used the appendix to come out. Although the base was sealed, so there will be no contamination, but you can wash it with the betadine and suck it. And now this is the suture which is pushed through the vagina, and this is the port closure started. We will start with the right side, taking the uterosacral ligament, and the epithelium also must be included. In the 3 port, you have to do everything yourself. Although we can do the hysterectomy by 2 port also. There is one of my video you can find out on the YouTube, in which we have done only single-handed, single instrument hysterectomy, but that is not good. So at least 3 ports should be there, one for telescope, one for your left hand, one for your right hand. So here we will take 2 layer suturing. In the first layer, it will not be locked. You can keep it loose, so that you can take the posterior and anterior separately. Care should be taken that after anchoring the anterior, you should pull it cranially and then rotate the needle. And now this is the corner is locked. You should bring the suture little lateral, and there is a lock on the corner. And after that, you can pull the tail also together to make it sliding, and then you can return back. And during returning back, every time we will lock it, so that it will not become loose. Here our suture was little. Here our suture was little small than the required. Generally we should use 40 centimeter suture for the vault closure. So it is reached to the again right corner, and with the same tail we will tie the knot. This is surgeon's knot. First time double wrap followed by 2 opposite alternating wrap. So 3 knot has to be taken. One time double wrap followed by 2 opposite alternating. So 2 1 1. Sometime if the tail is big, then the last C you can take it by the tail also. And it is done. After that you can hold the suture and do some suction irrigation to check for any bleeding and to check all the other structure. Little irrigation to wash. So now everything is okay. Now the final suture will be cut out, and then you can pull it through the 5 mm port. Cannula also has to be removed. After that, under vision we will pull the infrared ureteric catheter. Which you can see either side. It is slowly assistant will pull it. There is no cystoscopy required because it is already outside. We can see this is the right side of infrared. This is a Striker U kit we are using here, and the camera is 1688 of the Striker. So this is either side, and slowly it is going out. You can see infrared ureteric catheter is going out and it is pulled. So thank you very much for watching this video. This was a simple case of TLH with the appendectomy.